Welcome all to this special webinar event in collaboration with Microbiome Labs and Fullscript. I'm Amy Regan from Fullscript, and I'm so glad that you've joined us today. A few housekeeping notes. Please place all questions you have in the Q&A box for a chance for them to be answered. And we'll also hold some time at the end of the presentation to do some Q&A as well, hopefully. This webinar is being recorded, and the recording will be sent via email to all attendees and registrants, as well as available to watch at fullscript.com/webinars a few days after this event. There is a copy of the presentation slides in the handout section for you to follow along. It is my pleasure to welcome and announce our today's speakers. Dr. Lauren Zachariah is a pharmacist, nutritionist, and professor specializing in functional medicine and personalized nutrition. In addition to running a clinical practice focused on providing patients with sustainable solutions that address chronic disease, she also spends her time teaching and mentoring clinicians interested in implementing nutrition and food as medicine principles in practice. Welcome, Dr. Laura. We also are so excited to be joined by Lacey Hall, who is a registered dietitian with a master's degree in clinical nutrition. She is an expert in the intricacies of the human gut microbiome. At Microbiome Labs, Lacey is the head of scientific affairs. She educates clinicians about the gut microbiome testing, therapeutic interventions, and targeted strategies to support a balanced gut ecology. Her goal is to help advance the field of integrative medicine through evidence-based recommendations and treatment protocols that help drive better patient outcomes. Welcome, everyone.
Hey, it's great to be here.
Thank you, Amy, for that super warm introduction. Lacey, I'm so excited about this conversation. We get a lot of questions about strain-specific interventions for our patient care. And I think that's really a great conversation to have. But what we're doing today, what you set up for us is this beautiful journey talking about the foundations of the microbiome, of gut health. And I sort of equate it to setting up our soil so that we can have a really great environment to nurture and regrow the microbiome so that we can then set it up for success when we do use those direct interventions. So I see it as like setting up the foundation, setting up the groundwork, really doing that root cause medicine, and then addressing the specific interventions to help provide some immediate acute relief for our patients. So layering the two on top of each other. So I'm so excited to get started and get this conversation going. And I want to again remind everybody, plug your questions into the Q&A. We'll get the conversation in the chat going. We really want to make sure this is interactive. And at the end of the day, we want to make sure this is applicable and actionable for all our clinicians out there.
Awesome. Thank you. Yes, really happy to be here. It's a pleasure speaking on something that I love educating on. And I don't think it's any secret that the world of probiotics and understanding of the gut microbiome is a mystery to a lot of people. So today we want to break down some of the foundational aspects to a healthy microbiome, and then really come at you with some targeted strategies that are easy to implement in your office, that are very actionable, that will deliver patient outcomes. Because, hey, that's what it's all about. You're known for what you're delivering to your patients. So we stand by the research and the science of what we're preaching, and we're spreading that microbiome gospel. So let's get started here. Disclaimer, of course, I am from Microbiome Labs. This is intended for healthcare providers, and we encourage you to reach out to a healthcare provider if you're a patient on this podcast today or on this webinar. Key points. I'm not going to go through all these in depth right now. I want to get to the meat of the content, but we're going to focus on metabolic endotoxemia as our first big topic to really dissect. It's a big word that a lot of people may have some understanding with or none at all, but we'll really break it down today. And then we'll talk about that metabolic endotoxemia as it relates to chronic inflammation and different conditions that your patients can be struggling with. And then from there, what are the solutions? Because really we want to find those evidence-based solutions and practical things that we can implement on a day-to-day basis. And we'll go from there. So let's talk about metabolic endotoxemia and intestinal permeability. Laura, did you have anything to say about this slide first?
The only thing I want to say is I think when we think about endotoxemia, I hear that word a lot, right? And I hear a lot of clinicians sort of use that word And I don't know that we're all kind of understanding that this is the main this is the communication network that's happening between the gut and every other organ. So when we talk about endotoxemia, I think of it as the cell tower. I think of it as the way that the conversation that's happening locally in the gut, the hormones, the neurotransmitter, all those byproducts of metabolism that are happening in the gut, how they're getting communicated to the rest of the system. So yeah, take it away, Lacey.
Sure. Let's dive in. Let's just go into what it means and what it means for your patients. Yes. Okay, so we're going to go into the depths of the gut microbiome, something that's not visible to the naked eye, right? It's a lot like an iceberg. We can only really get a gauge of maybe some GI symptoms, but so much more is happening. So let's dive into the depths of the gut microbiome. From your mouth to your anus, it's a good 20, 25 feet. So there's a lot to unravel there, but most of your gut microbiome is really just residing in that last 5 feet of your colon. When we look at this pretty picture here, we see the gut lumen. It looks like a bunch of confetti. This is a picture of all those microorganisms. That confetti represents the microbiome. From there, you should have this thick green on the picture, not in real life, this thick layer of mucus. This barrier is very important as it separates that gut microbiome from the epithelial barrier of your gut colonocytes or enterocytes that are lining your digestive tract. That mucosal barrier becomes really imperative for protecting really your immune system from having to deal with a bunch of bacteria that's putting pressure on the immune system. But this isn't always the ideal situation that patients present with. What is a healthy gut microbiome to start off with? A healthy gut microbiome is something that's active. It's a part of you, and it's creating a functionality in your body. A gut microbiome that's healthy is producing bioactive compounds like postbiotics. These come in the forms of things like short-chain fatty acids. They can also be hormones. They can also be neurotransmitters. Your gut is your largest enteric organ in your entire body, endocrine organ, and we want to make sure that we're supporting it. A healthy microbiome contributes to a well-functioning intestinal barrier. A healthy gut microbiome will help keep your intestinal barrier intact. And a healthy gut microbiome has a low inflammatory load. So understanding the types of microorganisms that are living in this ecosystem is important. And there's always going to be a bit of a teeter-totter balance of who is living there and what they're doing for you. And we also know that a healthy gut microbiome is very resilient, and it's linked to fewer chronic diseases. And those can come in the forms of autoimmunity, can come in the forms of Alzheimer's and Parkinson's, metabolic derangements like diabetes, type 2 diabetes, so on and so forth. So the gut microbiome has a pretty direct link to almost all diseases that we talk about and research today. And so keeping it at its most healthy is of importance for everyone. So let's take a look at a schematic here that we show quite a bit, and I'll break it down further with some of the text that is over the pictures. A healthy gut microbiome on the left. What are some of the key characteristics that we're looking for? We want a lot of microbial diversity. That simply means we want a lot of different types of bacteria that are living in this ecosystem. The more the merrier. That creates a lot of competition in this space, and it prevents pathogens from overgrowing. Then we want those good microbes to produce, it went on for me. We want them to produce bioactive compounds like short-chain fatty acids. These include butyrate, propionate, acetate, and there's others as well. These are sort of our smoke signals that leave our gut microbiome, and they act as those transmitters of information that go out to other parts of the body, whether it's the liver, the brain, the heart. Short-chain fatty acids are really important. Underneath this gut microbiome where all your organisms live is that mucosal barrier. So we want that thick, intact mucosal barrier. And that's going to protect the epithelial barrier. Now, this is a very ideal situation. Let's dissect when it's not so ideal. We know that when it's not ideal and there is a low level of microbial diversity that we see in this image here, that we... let me see, am I able to use this? I am. We've got a nice little animator that I can use. So up at top here, we see our gut microbiome. In this picture here, there aren't a lot of different organisms. So a lot of diversity, not a lot of diversity, excuse me. Now, when there isn't a lot of microbial diversity, oftentimes that means that more pathogens and pathobionts are residing in this ecosystem. Now, in the cell wall of many of pathobiont and pathogens lives something called lipopolysaccharide. Lipopolysaccharide is an inflammatory compound, and when it's in high levels, it can really lead to tons of inflammation on the body. So that's what we're going to focus on here. Under cases and environments of low microbial diversity, we will see bacteria eating away at this mucosal barrier. So we see a breach in this barrier that becomes impossible for your very thin layer of epithelial cells to protect against. It's one single layer of cells up against all of these microorganisms, which make it really hard for them to defend against, essentially. So a breach in this barrier leads to lipopolysaccharide actually getting into your bloodstream. And this is where your immune system is waiting. Your immune system lives at the very other side of this epithelial barrier. And that's why we say 70% of your immune system lives in your gut. It's there as a training camp for your immune system and provides tons of functions. But if there are breaches in this barrier throughout the long intestinal tract, that's going to put a lot of pressure on your immune system. So let's go a little bit further. This lipopolysaccharide is a large molecule that's found in the outer layer of gram-negative bacteria. Gram-negative bacteria are those pathogens, those pathobionts. They all reside in one phylum within the microbiome. Phylum is basically just a really big category of where bacteria live. So lipopolysaccharide types of organisms reside in the proteobacteria phylum. Now, we're always going to have some of them in our gut. It's impossible to say that we should have none because some element of controlled inflammation is a positive thing for our body. We just want to make sure we keep it in check. That's really the overall headline with understanding how much lipopolysaccharide should be present in our gut and entering our body. We can't avoid it completely. That's impossible. We just want to make sure we have it in balance. But when it does get out of balance, it becomes very inflammatory and very immunogenic. Your immune system has a tough time figuring out what to do with all of this, and it creates a cascade or a snowball that goes out of control. So when that lipopolysaccharide begins to breach this barrier, it is entering into the bloodstream. Now, once it enters into the bloodstream, lipopolysaccharide will bind to lipopolysaccharide binding protein, LBP for short. So it's bound up by the immune system, trying to figure out, what do I do with this? Then it's actually going to take it to the CD14 complex, usually on a immune cell like a monocyte. Sometimes a dendritic cell will get in the action. But that immune cell then wants to decide what to do with this. Is this a friend or is this a foe? That's a big component of immune health, of determining self versus non-self. Now, in this case, it of course is a foe. So what does it do? It activates NF-kappa beta inflammatory cascades and pathways, and this leads to the production of pro-inflammatory cytokines like tumor necrosis factor alpha, interleukin-6, so on and so forth. There's plenty that can be released because of this. Now, this is fine and dandy if it happens one time, two times, a few times in your body. Your body is resilient and it can deal with levels of inflammation on a day-to-day basis. But when it's happening over and over throughout the greater parts of your gut and your intestinal tract, that can create major problems for your patients. It's just like throwing fuel on a fire. So this creates this state of chronic low-grade inflammation. The coals and the embers that are burning in the background that are making it more difficult for you, the provider, to truly get to the root cause of what's driving your patient's symptoms, whether it is having to do with hormone imbalances, cortisol issues, which we'll touch upon a little bit later, metabolic health and weight loss, or even gut-brain axis and brain fog, or gut-liver dysfunction. If we don't get this low-grade chronic inflammation under control, then you're going to have a much more difficult time truly getting your patients to be symptom-free, whatever it is you're dealing with. So to summarize a little bit about what metabolic endotoxemia is, really is an immune response that drives this low-grade chronic inflammation really because of the composition of the gut microbiome. And when that composition shifts to an environment that has more lipopolysaccharide, that's when we see this inflammatory cycle and that snowball effect persist. Now, the numbers are not perfect. We have no idea how many this affects. We say about 33% of the Western population. I would say it's probably a lot higher. If you go into PubMed and you start typing around information about metabolic endotoxemia, you'll get different facts and figures depending on the source. Now, in a very acute situation, metabolic endotoxemia is actually sepsis. So what we're talking about is a low-grade sepsis that's happening in our population. This is characterized by an increase in serum lipopolysaccharide during the first 5 hours after eating. That's when we see the biggest spike, and we'll talk a little bit about the dietary links to big spikes in lipopolysaccharide concentration, because we know that fat is actually one of the biggest drivers of LPS entering our bloodstream. Now, when it does enter the bloodstream, when the immune system is reacted, we see that cascade of pro-inflammatory cytokines being released, but we also see some of those metabolic derangements and changes in things like triglyceride levels, postprandial insulin levels, ghrelin, leptin, and glucagon levels also shifting because of this state of inflammation that we're putting the body in. So it's not of course we want it there, it's a protective mechanism, but the point is it can get out of control. So we want to make sure that we are finding ways to control it. So I touched barely on how dietary fat causes a release of LPS. Now, this is a great study. I encourage you to dig into it. It looks at diet quality on metabolic endotoxemia. It's a review paper. And what we found is in this paper, some of the big takeaways, if you look to the right, the first graph here, we have LPS in normal weight subjects here. We see that at baseline, before consuming a high-fat meal, we see that there is a little bit of lipopolysaccharide that's circulating in the serum. Now, about 5 hours postprandially, we see this big spike. So we see this big shooting up of lipopolysaccharide that's entering into the bloodstream, causing this inflammatory state. Now, if we take a look at subjects that are overweight, their baseline for metabolic or for lipopolysaccharide in their serum is already 3 times that of a normal weight subject. So their baseline for starting out, it's double. It's a little bit small on my side. So it's double what was in the healthy weight subjects. And we see, again, this bit of a dramatic spike here after consuming a high-fat meal. So to do these types of exercises, you need to be there in real time, where you're testing lipopolysaccharide in the blood at a number of times during the experimental model. It's more difficult to capture in laboratory tests that are done in clinic. I don't really think that there's a gold standard that's been established yet. It's typically a question I get. There's really nothing that we can do to truly assess what's in the bloodstream at a real time, unless you're in a more research facility or setting. Now, we can look at the types of microbes, though. That's one clue that we can look at. Now, we know that changes in LPS after eating saturated fat intake is much more dramatic than compared to consuming polyunsaturated fatty acids. This isn't a shaming exercise of saying don't eat saturated fatty acids. We don't believe that at all. We know that they're very important to creating hormones, to supporting the brain. So it's not the message we want to get across, but it is about the balance and the diet quality. And again, going back to who is living in the gut. So a little bit of a takeaway here. We know that saturated fats and omega-3s or polyunsaturated fats have opposite effects on the LPS receptor, and that the lipid A component, which is the most toxic component of lipopolysaccharide, is actually composed of saturated fat. So that's one of the reasons why the body recognizes it and pulls it in. And we know that we can reduce the toxicity of this lipopolysaccharide endotoxin when we substitute omega-3s for saturated fatty acids. Again, overall diet quality is really important. It becomes a look of what is the overall quality of the diet that we can examine, rather than one thing in isolation.
Wow, you really just tied so neatly in a bow sometimes we hear these conversations about how leaky gut increases your risk of diabetes, or why it is that inflammation starts in the gut, right? And what you did there was kind of help us close the loop, because when you've got somebody that has hyperpermeability, i.e. leaky gut, you're going to increase that risk of endotoxemia. And when you combine that, when you look at specifically the changes in triglycerides, postprandial insulin, and the mediator that is inflammation, you can start to see really for clinicians are trying to explain this picture. Hey, doc, why are we talking about my gut when it's my cholesterol numbers that are off? It really helps us to kind of have that conversation and help them really understand foundationally what might be happening in their gut that's influencing those numbers. And for me, that moment where you're talking about saturated fat, again, we see all these studies talking about the different kinds of fats and why these population studies sort of point to saturated fat and say that that's a problem. You pinpointed the mechanism for us. So it's the environment that saturated fat is in, the balanced against the other polyunsaturated and omega-3 fats that we know have a beneficial neutralizing effect. And just what a beautiful way to help us understand the metabolic process. Now, I'm excited to hear about the gut-brain aspect.
Yes, and we'll go back to some of that metabolic process later, too, research studies as well. But
the metabolic piece is always going to come up, right? That's the engine that's running the whole thing.
Always. But with that, if you're new to the microbiome, or if you kind of toggle around with, throwing probiotics at a patient, understand what you're doing. And it really needs to come back to, are you solving for that part of the equation? That's number one. And that's not supplements alone. A huge portion of that is really just going to be diet quality, which, feels very intuitive, but it always is, more complex and challenging to change those patient behaviors. But that is number one when healing gut health. Don't get lost in all of the complicated protocols. That really needs to be step one. So let's pivot to talk about brain health. Now, the gut and brain are originally formed from the same neural tissue when in utero, and they differentiate during tons of changes and processes as we develop, but there's always that strong connection. And in fact, 90% of the communication in the gut-brain pathway comes from the gut. Your gut is always telling your brain what's going on, but they're not in isolation either. And many of you have probably heard the term leaky gut, leaky brain, and it's in fact very true. Now, that lipopolysaccharide, when it leaves the gut and it triggers the immune system to create pro-inflammatory cytokines, the story does not end there. It would be a lot easier if it did, but no, it's going to complicate our clinical scenario a little bit more. Now, lipopolysaccharide is actually able to cross the blood-brain barrier. It can impair the blood-brain barrier, in fact, and we find that it can initiate another immune response within the brain by activating microglial cells, which is our resident immune cells living in our brain, similar to white blood cells, which can go on to trigger the very same processes and pathways to create pro-inflammatory cytokines like interleukin-6, tumor necrosis factor alpha, interleukin-1 beta, et cetera, And this gets into the way of memory, of cognition, of how we deal with stress, and then just creates an overall state of neuroinflammation. And so what stays in the gut what happens in the gut doesn't stay in the gut. Sorry, I butchered that saying, unfortunately. So when it does leach out into the periphery, it does create this systemic state of inflammation that does drive issues with brain function as well. Now, metabolic endotoxemia, how does it affect our mood and behavior? We know that in a higher endotoxic state, it can create a state of depression. And right now, when we look to mental health and what are the solutions out there, most of the pharmacological solutions and interventions have just been different iterations of Prozac over the last 30 years or so. There's really not been a lot of advancement there. And there's some that theorize that one of the challenges is that we haven't actually healed the gut as the driving factor beyond, what could help improve some of these mental health conditions that are challenging to treat. We know that this endotoxemia creates an inflammation-associated depression, and there's tons of different, especially animal models are easier to run, more ethically, of course, that confirm this. But we also know, again, when we create this low-grade state of inflammation with elevated pro-inflammatory cytokines, we see increases in sadness and anxiety. And this correlates with the spike in endotoxemia, that lipopolysaccharide in the bloodstream, that 4 to 5 hours after consuming a high-fat meal. Now, when we look to the right here at our image here, the individual, we see that endotoxin administration is small. Just 0.4 to 1 nanogram per kilogram can initiate this systemic inflammatory response, leading to behavioral changes, modulations in brain function, and overall inflammatory markers. that we've seen over and over in the research. Now, what can we do about it? Of course, we can think about doing CBT, cognitive behavior therapies, and different types of psychological trainings. We can utilize different types of pharmacological drugs, and specifically those that block something called an IDO receptor, and we'll get into IDO later. And then we can target inflammation, right, with different drugs, different therapies, different nutritional interventions. But does it get to the core? And the answer is no, because if the problem is endotoxemia, it's a problem with the bacteria, not with all these other things. You're throwing water on the fire, but it's a big old fire. You need more than a bucket. You're going to need to actually get to what's causing that fire to persist. So when we think about inflammation, how it influences the tryptophan pathway, this is a really important slide. We'll go back to a couple of other times as we talk about the gut-brain axis. But tryptophan, as many of you know, is an essential amino acid. And most of us think of tryptophan, especially this time of year with Thanksgiving around the corner. Tryptophan turns into serotonin, then it turns into melatonin, right? And then we're happy, we're sleeping, and we're feeling good. That's what we want to happen with tryptophan, right? That's our happy, beautiful ending. But the reality is, under a state of inflammation stemming from the gut microbiome, this little enzyme here called IDO, indolamine dioxygenase, is turned on. It's a little light switch that goes off. Now, this is going to tell tryptophan, oh, we're going to shuttle you down this way. We're going to go down a different pathway, and we're going to activate the kynurenine pathway. So tryptophan can turn into kynurenine, and under a happy ending, it may get shifted over to kynurenic acid, which is a little more neuroprotective. But under strong states of inflammation, that kynurenine is going to become quinolinic acid. Quinolinic acid is neurotoxic, and it can lead to increases in depressed mood, irritability, reduced resilience to stress, poor sleep, and poor concentration. So again, just going back to the site of where everything matters, the composition of the gut microbiome plays a huge role in whether or not that IDO enzyme is actually turned on. So that becomes important in that gut-brain connection. We know lipopolysaccharide, again, leaves the gut. It can enter the brain, crossing the blood-brain barrier. And in Alzheimer's patients and post-mortem analysis, we see that lipopolysaccharide is enriched in the perinuclear region of Alzheimer's, which is a driver of the disease. So we see a direct link there. But we also see a direct link between altered gut microbiome, permeability, and intestinal pathology, and things like Parkinson's disease. In fact, one of the very first symptoms of Parkinson's disease is constipation. And high levels of lipopolysaccharide can be a driver of constipation, especially as it damages the vagus nerve. But we also know that these endotoxins can induce alpha-synuclein aggregations in the central nervous system by way of that vagus nerve. So driving the pathology and the etiology of Parkinson's disease, making it more difficult to manage. So it's two huge conditions that face many patients and families today. Here's just I'm not going to go through all of these in the interest of time, but many conditions have mechanisms that are aggravated because of elevations in lipopolysaccharide. So I think that for you as clinicians, take a look at this. What types of patients are you dealing with? And what are ways in which we can truly help to reverse this, or at least pause it or slow it down from aggravating or worsening conditions?
Absolutely. So unlike vagus, what happens in the gut does not stay in the gut, because it's going to be constantly communicated to every part of the body, every system. I love that you brought up that tryptophan mechanism, because I think it really highlights, just like we said with the saturated fats, and the idea that with the right microbial environment, the switches that turn on tend to be protective and tend to allow the system to run and hum the way it's supposed to be. When the switches are turned off, we need to start looking at the gut and at the signaling and the messaging that's coming from that piece. So to your point, we're not saying that don't use SSRIs, SNRIs. That's not the takeaway here, but you could see how you're kind of not going to get the most benefit out of them if all you're doing is turning up the pathways that produce serotonin, but you're not addressing inflammation. You're not addressing mitochondrial health. You're not addressing metabolism, that is going to essentially not get the benefits. And we see that the literature bears that out. We see it in our clinical practices where our patients don't do as well as we'd like them to do, right? And so I think this is an opportunity for us to say, and not or.
Exactly. And all the way. I'm a big proponent of integrative medicine, and I truly believe there's a place for both. And this is, maybe you can get them 80% there, but maybe this is that 20% that you needed to unlock to really get them to the finish line. So
absolutely. And you're going to get all those comorbidities at the same time, right? You're going to improve their chronic disease risk overall, because we know there's also an overlap between the mental health and the neuroinflammation piece and all these other metabolic and long-term risks.
Absolutely. Yes, I couldn't agree more. Great. Okay, so what are we going to do about it? I think that actionable takeaways become, really, of course, important here. So let's touch upon some of the things that we can do as clinicians. Minimizing alcohol consumption, really looking at diet quality, macronutrients, making sure that we have a lot of plant fibers that are feeding our gut microbiome, specifically full of antioxidants and prebiotics. Reducing or at least assessing saturated fat. I don't want to say reducing, because I think it just depends on where that person is. There's plenty of people that don't eat enough, but then there are others that, hey, they go overboard. I think we can see that. And then weaving in next generation probiotics, prebiotics, and postbiotics, which we'll touch upon later. So here's another review paper if you want to dive into how to mitigate some of the challenges and ways to reduce metabolic endotoxemia in patients. And if this is a new concept for you, please go into PubMed, type in dietary induced metabolic endotoxemia. You'll have 40 plus pages, because this is a very common model to initiate inflammation. It's been around for a long time. And so it's something that we have a lot of knowledge about here at Microbiome Labs. So what are some practical approaches? Of course, there's different methods and protocols out there. We want to start with reconditioning the gut. Reconditioning the gut is really just rebalancing those microorganisms and increasing diversity. That is number one. If there is an important pillar to a healthy gut microbiome, diversity is number one. You cannot have a healthy gut microbiome if you don't have a lot of species and beneficial species that are living there. So not one thing can do it. It's got to be stress management. It's got to be diet quality, fiber intake. And then, of course, we can utilize really great nutraceuticals to get us there faster and more effectively. We want to reinforce the changes. If we are kind of essentially planting the seeds of these microbes, we want to give them the foods that they like to eat. We know what they like to eat in terms of fibers and oligosaccharides. It's going to create a more stable population. It will also increase diversity, and will make them work more. So it'll create a more functional microbiome where they're creating different bioactive compounds like short-chain fatty acids that, again, create the signals throughout the body. We want those signaling molecules to be telling your brain, your liver, your heart, your hormones, what's going on, and help to rebalance. And then we want to rebuild the intestinal mucosal barrier. A lot of times, again, if you do have dysbiosis, if you have a lot of pathogens, those microbes like to eat mucus. They eat it down. They chomp it down like Pac-Man. So we want to support a healthy and robust mucosal barrier. This helps reduce inflammation. It helps give your immune system a break too. Remember, if your immune system has to deal with all of these breaches in the barrier, then hey, it's probably pretty on fire right now. So we want to give it the break that it deserves. So let's go through each of these. So here we have a study. It's a 30-day intake of a spore-based probiotic under those dietary-induced metabolic endotoxemia types. So essentially, college students came into a research facility. They were bribed with free pizza. Researchers told them, eat as much pizza as you want. So these college students came in, they ate a bunch of pizza. They tested their blood at baseline for lipopolysaccharide. The subsequent hours afterwards, we saw the biggest spike at hour 5, just like we do in other research studies. So we saw the biggest spike of serum lipopolysaccharide at that 5-hour mark. Now, they told the students, hey, go home. I want you to take this pill each day for 30 days. Some are taking a placebo. Some are taking a spore-based probiotic. They did that for 30 days, came back to the research facility, did the exact same thing. Ate a bunch of pizza, tested their blood. What did we see? We saw that in the placebo group from baseline, there was actually a 32% increase in their lipopolysaccharide levels. Who knows why? We didn't tell them to actually change their diet or do anything different. They're college students. You don't really know what they're doing, staying up late, partying, eating, drinking, all the things that college students do. But in the group that was taking the spore-based probiotic, we saw a 45% reduction in lipopolysaccharide. So a pretty big gap between these two. Now, that tells us a lot of things about what's going on and the ability for bacterial spores to help correct that foundation. Again, helping to improve microbial diversity, helping to increase short-chain fatty acid, and really helping to heal that gut. Now, there were some other things that we found in this study that were very fascinating. Again, because we are actually changing the environment of the gut microbiome, we want to think of the gut as a gateway to all other parts of the body. We saw improvements at that 5-hour mark in insulin response. We saw improvements in glucagon response, and then we saw reductions in interferon gamma response as well. So again, painting a more complete metabolic health picture of how healing the gut can trigger other pathways and really help to correct imbalances in the body. There were other findings as well, if you want to dig into this study around ghrelin. Some things started to trend toward positive, weren't there yet. Maybe if we supplemented a little bit longer. That study is actually running again at a longer period of time. Now, step 2 to this process, reinforce. Now, say we plant those seeds of those bacillus spore-based bacteria. They're helping to lower lipopolysaccharide. That's great. Now, let's really reinforce these changes. So we want to give those bacteria the foods that they need in order to grow. That helps create a more stable environment, a stronger ecosystem. Think of a rainforest versus a desert. Your gut, we want it to look as close to a rainforest as possible, full of different species, full of richness, full of nutrients, full of life, versus a very sad and dysbiotic gut with only a few species there. So when we start feeding those bacteria prebiotic fibers, then we should hopefully get closer to that rainforest picture in your mind. So this is a study here, and this is done in an in vitro simulation of what a GI tract looks like. It's called a SHIME model. It's a simulated intestinal microbiome ecosystem. Now, again, your gut is a closed world. It's hard to see what is going on in there, and it's hard to manipulate human behavior too. So here we created this simulated ecosystem and fed it the spores, and then we added in some prebiotic fibers to measure the changes. Now, these are some of the results. We saw in 3 different types of donors, we had a few donors in this study. We saw increases in bifidobacteria in the ascending colon, the transverse colon, and the descending colon. And then we saw huge increases in Faecalibacterium prausnitzii, which is a keystone species of bacteria, one of the healthiest groups that you can have in the gut. We saw increases in lactobacillus in all areas of the colon, and we saw increases in Akkermansia. Of course, Akkermansia is a hot topic of bacteria right now, next generation probiotic. But what if you can just grow it on your own with the right inputs? You have your own little ecosystem living there, and if you give it the foods that it wants, it will respond. Your gut is a flexible organ, and it changes with you. And that goes on with the foods that we're putting in our body and the supplements that we're taking. So just a combination of 2 types of supplements that are out there. We see these more global changes of, again, creating that stable base of keystone species of bacteria that are your most healthy, and then changes in short-chain fatty acids, what they're doing for you, which is most important. So in the different donor types, in the ascending colon, we see total levels of short-chain fatty acids spike. They go up quite a bit after introducing the probiotic and prebiotic. We see butyric acid making up most of that, which is arguably your most beneficial short-chain fatty acid. We see this in the transverse colon as well, big spikes in butyric acid and in acetate. And then again, consistently huge spike in short-chain fatty acid production in the descending colon, with most notable increases in butyrate and acetate. Propionate, not responding as much, but I'll take it. Essentially, those bacteria are working, they're consuming the fibers, they're creating the postbiotic molecules of short-chain fatty acids. Short chain fatty acids don't just stay in the gut. They go out, they become the signaling molecules and the way in which your gut is communicating with the rest of your body. So I'll leave this one here as more of a reference slide to go back to if you want more information there. Now, the third step in fixing the gut in a very simplistic protocol is utilizing bovine immunoglobulins. Bovine immunoglobulins have been used in supplements for a really long time, or not a long time, but they're very widely used right now. I think of them as really a bacterial toxin sponge. They're there to mop up all of the toxins from bacteria, and it gives your immune system a break. Now, this study here, 40 to 5-day oral supplementation with a serum bovine-derived immunoglobulin, it's a mouthful, just call it SBI. In this, the researchers were looking at inducing dietary endotoxins, and after 45 days, looking at, again, what's going on after eating these high-fat, high-calorie meals and the response. So the response after 45 days, there was trends to a reduction in cholesterol and the pro-inflammatory cytokines. They weren't looking at the lipopolysaccharide in this, but again, globally looking at overall metabolic health and how this is going to improve patient health by changing bacteria, not other things and strategies within your repertoire and your toolbox. So serum bovine immunoglobulins, they're known to bind, again, a variety of bacterial toxins. But here I have the arrow pointing at lipopolysaccharide. But they also bind to things like H. pylori toxins, Candida, Shiga toxin, so on and so forth. I think now it's even expanded further to bind to different mycotoxins. And I think there may be some Lyme associations as well with this SBIs and their use. There's quite a bit of benefit, but I think of them as passive immunity. It's giving your immune system the break that it needs so it can deal with more important things than a leaky gut. So it's very important, very useful, and patients feel the relief pretty quickly, which they love and are appreciative of. Now, other ways to support the mucosal barrier is with polyphenols. Dietary polyphenols, whether they're in supplement form or in dietary form, can help modulate the inflammatory response, but it can also help to seal and heal those tight junctions that become leaky over time. And we know that citrus polyphenols in particular then contribute to more short-chain fatty acid production, which is really essential to a well-functioning gut microbiome. And it also is known to reduce fecal calprotectin, an overall inflammatory marker of gut health, so by a pretty significant amount. And then last but not least, as we look at mucus and mucosal barrier, we know that certain amino acids are really important for increasing mucus production, and that these specific amino acids can help increase colonic mucin synthesis by 95%. So again, creating that thick, robust barrier between the microbiome, the mucosal barrier, and then that third layer being the enterocytes or colonocytes above your immune system.
Yeah, so it's I think of that mucosal barrier as being like the little greenhouse that we can protect and allow the microbiome to thrive in, and all of those little factories that are churning out those short chain fatty acids. But I want to make sure everybody caught that, because yes, sometimes we'll see our patients feel better. They'll tell you, I feel better. Their symptom report comes back and it's improved. But what you highlighted there are two really salient endpoints. One is the reduction in inflammatory markers, number one. And number two is the increase in those short chain fatty acids. Mm-hmm. You know, you sort of joke like, I'll take what I can get, but that's actually really significant to see that butyrate, because that's so implicated in so much of that communication piece. To see that rise significantly, not only can we can kind of attribute the improvements in symptoms to a very specific endpoint. I think that's really important. And then you layer in the SBI, and you called it a sponge. I call it a lint brush. That it comes in and it picks up all the debris that's happening. And I usually, when I add it on, I'll add it on regardless. No matter what our next step is going to be, I usually put that right in there in the beginning, because of that lint brush effect. I know for a fact it's going to start to set that foundation of that mucosa. I know it's going to start to reduce inflammation. But then once you're sort of getting into the nitty gritty of changing the microbiome, it's going to help to reduce some of the Herxheimer reactions. Yeah. It's going to reduce that inevitable sort of shift in their symptoms to mitigate any of that potential risk increase in inflammation as we're getting everything kind of adjusted and rebalanced and moving things forward, especially if you're onboarding any antimicrobials or berberine or anything like that. So that's sort of like my go-to. So I'm really glad you showed us exactly how that's working.
Oh, yeah. It's very soothing. I'd say anyone that's presenting with loose stool, start them there. They're going to be your best friend afterwards, and you'll have them on board for a while. It's that, I think that you get a real quick effect from it, and that's why they've become so popular in using them. Yeah.
And we're talking about like the setting the foundation and then the acute care that, we just sort of covered all that right there, right? Before we even started talking about strains. And that's what I wanted folks to pay attention to is there's so much that you could do, and then you can really go in with specific strains.
Exactly. So let's pivot right now and talk about a psychobiotic, strain specific. So look to the spores for that foundation because they're hardy, they're resilient. We'll go into them a little bit more toward the end. But then let's get really prescriptive. And that's where strains become important, strain specificity. So let's talk about a psychobiotic. So, okay, we've got the gut. We've got lipopolysaccharide. We have lipopolysaccharide impacting the blood-brain barrier and impacting brain health. Now we can use a psychobiotic called 1714 that comes out of Ireland with a wonderful research group that has been studied for a really long time in specifically gut-brain health. 1714 has been studied in a bunch of different human clinical trials around stress, anxiety, depression, sleep quality, cognitive function, how to deal with social stress, and cortisol levels as well. There's quite a few studies backing it and showing its broad applications, especially in the gut-brain axis. Now, again, back to tryptophan. We know that tryptophan, essential amino acid, and it has, of course, the happy ending that we want in the serotonin pathway, becoming melatonin, creating a happy, healthy, balanced situation. But when it goes via the indole pathway, via gut bacteria, it can become tryptamine and other iterations of indoles, or last but not least, it can go down that kynurenine pathway, becoming quinolytic acid, which can be very neurotoxic. So that's the one that we're focused on here today. So with the composition of that gut microbiota, as we mentioned before, under a dysbiotic or pro-inflammatory gut microbiome, under stress as well, and a lot of taxation on the HPA axis and cortisol release, that IDO enzyme is turned on. It's like lighting a match. This indole diamine dioxygenase, when it's turned on, this can create a cascade of events that causes kynurenine. You now have a kind of a cross in the road. Is kynurenine going to become kynurenic acid and that little fire is extinguished? Or under pro-inflammatory situations, will it become quinolytic acid, where it leads to this neurotoxic pathway related to depressed mood, sleeplessness, restlessness, so on and so forth. So our goal is to help shuttle tryptophan down the right pathway. And how can we do this? We'll go back to that psychobiotic. Now, there is a top-down approach to what's going on with the hypothalamus and the HPA axis. When your adrenal glands secrete cortisol, this creates a leakiness in the gut. It's going to create increased intestinal permeability. It is just a natural process that happens. But again, what if you already have some leakiness in your gut and you have dysbiosis and you have high LPS that's already been breached into circulation? Well, we're going to add more to that, right? We're going to add more fuel to that fire. More LPS is leaching into the periphery. More LPS is triggering the immune system. More pro-inflammatory cytokines are being produced. Now, the thing is, cortisol is actually an anti-inflammatory hormone. It shuts itself off afterwards, after being released. There's usually this negative feedback loop telling the HPA axis to calm down, to relax. It's over. The stress is over. But if you have this persistent leakiness, this persistent release of lipopolysaccharide, and heightened levels of interleukin-6 in particular, this release of cortisol just continues. It continues on, and this causes this constant flux of pro-inflammatory cytokines, which can lead to this cortisol burnout or flattening when we look at cortisol levels in patients and their morning cortisol response. So the gut, again, what happens in the gut doesn't stay in the gut. It's impacting other pathways, causing cortisol to become dysregulated. And we see that link up with chronic stress, depression, anxiety, and irritable bowel syndrome as they all overlap in a beautiful little Venn diagram where it comes together. So irritable bowel syndrome is characterized similarly as the state of low-grade inflammation. We see similar levels of pro-inflammatory cytokines being released. We see a turn on of this IDO switch, an increase in kynurenine, which can lead to higher levels of quinolinic acid and neuroinflammation. So we see really similar pathways being triggered in an IBS model as we do in other low chronic inflammatory models that are happening in patients. And we want to, again, what is within our control to shift the destiny of tryptophan? That's really the question that we're looking to answer. Now, this bifidobacterial long gum 1714 has some very interesting mechanisms. Now, when it's consumed, it's absorbed in the distal portions of your small intestine, not your colon. In fact, dendritic cells reach across the mucosal barrier. They grab the bacterial strain, the 1714, and they engulf it. When they engulf it, they're trying to figure out, again, just like the immune system always does, is this a friend or is this a foe? Now, once it determines what it is, it has a tendency to create interleukin 10. Interleukin 10 blocks NF-kappa beta signaling, which is usually the trigger for pro-inflammatory cytokines. So it has an opposing effect. It has an anti-inflammatory effect. So the opposite of what happens with lipopolysaccharide. So this B. longum 1714, it actually acts by blocking inflammatory signals from happening. It helps shift toward a more anti-inflammatory balance within the body with more interleukin 10 secretion. And this just creates a broader response in the body to support the gut-brain axis. So a very unique mechanism of action as it can turn off that IDO switch that's been activated, right? We want tryptophan to go down the serotonin melatonin pathway. Over time, it does not happen overnight. It takes a while. It takes 3 days just for the dendritic cell to eat up this psychobiotic. But once it enters the periphery, as your body is kind of creating this loading dose of the psychobiotic, it helps to shift actual brain chemistry and brain function. So we want to support that shuttling of tryptophan toward the serotonin melatonin pathway that's more neuroprotective. So how does it do this? There's a couple of strains outside of 1714. We also have another one called 35624. Now, normally, again, the immune system is trying to figure out, are you a friend or are you a foe? Now, 1714 gets to traverse and move around the gut with a sense of neutrality. It's not going to create this alarm that's going off. And a lot of this is because of the outer layer of the bacteria itself. It's a sticky, mucousy layer called an exopolysaccharide. The exopolysaccharide acts as sort of an invisibility cloak. So it's not causing an alert for the immune system. Now, again, when it's engulfed by the dendritic cells, it's able to create and secrete IL-10. That's going to help to block inflammation and create an anti-inflammatory state within the body. So studying it, there are a number of clinical studies around the strain itself, but we have human clinical trials and then preclinical trials in animal models that are examining the relationship between the strain and anxiety and depression, psychological stress and responses, even cortisol response as well, and then in brain activity. So let's take a look at a couple of them. And this one, we look at the ability to cope with stress. We look at male volunteers here, and we're looking at cognition and an EEG and an acute stressful situation over 10 weeks. So in this study, we saw that 1714 helped reduce perceived stress, how you're actually allowing stress to enter your mind and your body, and then also cortisol output being reduced. And we saw a decrease in pro-inflammatory cytokines as well. So creating that overall change in the body, all stemming from the gut with use of a psychobiotic. In another study looking at 1714, we looked at stress response, electrophysiology, and neurocognition in a number of volunteers over 8 weeks. This was a crossover study where they started off taking a placebo, then they checked different outcomes, survey results, daily perceived stress, cortisol output, and anxiety. And then for 4 more weeks, they took the psychobiotic bifidoblanum 1714. So in this study, compared to a placebo, if we look here to the left, we have our anxiety level at baseline. So pre-set stress, post-stress, we see a spike in anxiety after a stressful event. In the placebo group, it stayed true almost identically. And then in the 1714 state, after 4 weeks of taking the psychobiotic, we see a reduction in overall perceived stress. Now, of course, that's great. That's statistically significant. But let's look at some clinical significance as well. Salivary cortisol, the area under the curve compared to the baseline and placebo is much lower for our 1714 subjects that were taking the psychobiotic. We also see this curve reduces very nicely, indicating that after the stressful situation happened, you're returning to baseline. And this is further corroborated with the total cortisol output being statistically significant, but also very clinically significant after 4 weeks of taking the psychobiotic as well. So cortisol levels being lower, also a healthier curve of a spike and a decrease, which is really important. Now we look at the way 1714 actually modulates brain activity during stress. So here we have a 4-week double-blind placebo-controlled trial, and patients were broken up into 2 groups where we look at different outcomes: brain waves at rest, brain waves during stress, and then different questionnaires around stress and quality of life. So this one's very interesting as we're actually mapping the brain. Here we see results with the bifidobacterial longum group. During the stressful events, we saw increases in theta band production. So here it's hard to see with the black marker, but the orange represents increases in theta waves that are being produced in the brain. These are released when you're in this flow state. We're in a relaxed state. We want high theta brain waves to help us stay calm. So this correlates with a reduction in that perceived stress that people are experiencing. And then we saw that compared to the placebo, there were higher alpha waves as well in the 1714 group. And this is more correlative to things like meditation and calmness. So after taking the product for a month, we see increases in theta and alpha. Now, at the same time, we saw a reduction in beta wave activity. And beta waves are associated with more anxiety, agitation, even ADHD. So we saw an inverse: higher theta and alpha, lower beta as well. All right. So how does this work again? Just to summarize really quickly, 1714 increases anti-inflammatory cytokine interleukin 10, blocking the NF-sigma-kappa pathway and inhibiting the production of pro-inflammatory cytokines. So when we talk about strain specificity, we're really getting to the root of how we can shift tryptophan metabolism toward a more neuroprotective pathway. So I'll leave this as a reference in the interest of time, if that's okay, so I can move on to therapeutic intervention. Okay.
This is the good part.
Okay.
Well, it's all been great. This is this is what everybody's looking for. What do we do? How do I do that?
Okay, so we talked a little bit about spores as being our foundation. We wove in one strain-specific type of bacteria, 1714, and there's lots of strains out there. So, of course, we have probiotics that are the live microorganisms. We have prebiotics. These are the food sources for those microorganisms. We have symbiotics where they're combined, and we have postbiotics, which could be dead bacteria. They can be short-chain fatty acids that you're consuming. They can be even different compounds of yeast metabolism and fungal metabolism in the form of enzymes. That's another way that we can kind of classify a postbiotic. So again, just a way of looking at different examples. Now, I like to to really take apart probiotics and spore-based probiotics, because I do think that they are different. Probiotics, they are like live microorganisms. When administered, provide a health benefit to you. But we need to use very specific strains for a very specific reason. And that's where I hope this world evolves to, because I think most providers, they want to look at the back of a supplement facts panel. They're like, oh, this one has the most. That's how I'm going to use it. And I get that. That's definitely what I used to do. I'm a little biased because of my actual job. Now, I want to encourage you to know, what is the research supporting for the use of that? Why are you using it? If you don't know why, I'm not saying don't use it, but learn so that you can be very personalized with your recommendations, because it does matter. Just because there's more strains in there doesn't mean it's going to increase diversity. It's probably not, unless there's some research to show that it will. Spore-based probiotics are different because they are more hardy. They are known to survive digestion and remain alive, and there is research supporting their use in improving gut health and improving diversity and that overall foundation. So it's very foundational. From there, I like to use the different types of probiotics, the bifido strains, the lactobacillus strains, whether it's for diarrhea, whether it's for binding H. pylori, whether it's for supporting the gut-brain axis. There's very specific strains for purposes. Psychobiotics are specifically targeted to improve the gut-brain axis. Postbiotics can be in the form of a dead bacteria that still has a lot of use. Again, with the 1714, we're more concerned with the exopolysaccharides. So it's not always the bacteria itself. It can be bacterial components that become really important. And then prebiotic fibers. So we can get fibers from food, but we can isolate out these oligosaccharides that specifically help to grow our most healthy groups of bacteria as well. Okay. So let's see. Going over to the specificity of probiotics, we don't want to just use something called lactobacillus. It's very general. And bacteria, it is like a barcode. The tiniest changes in the type of strain will dictate its actual purpose. We don't want to just do the species level. Species is still too broad. That's like going from using a rotary phone to an iPhone. But we want to know what kind of iPhone. Do you have the 256 gigabyte that's black? That's like getting down to the strain level. So we really want to know exactly what its purpose is. And the companies that you work with should have committed to research to tell you what they are for. If they can't, then I wouldn't use it, because I think that's their responsibility if you're going to put that in your patient's hands. Spore-based benefits, they have been shown to increase diversity. Again, what is the number one pillar of a healthy gut microbiome? It's a diverse microbiome. So I encourage you to start there. And they can help support the growth of lactobacillus and bifidobacteria. May seem counterintuitive, but we're feeding it vitamins, nutrients, different compounds that feed those healthy groups of bacteria. So it creates a stronger ecosystem. Spore-based probiotics can also secrete antimicrobial compounds and different peptides that can control the growth of unwanted organisms. They're known to survive to a fault. They can survive. Some people think they came on over from outer space on a comet. I think they can survive anything. They're very rugged, which allows them to be very versatile in patient use. And they don't stay in your body forever. They do colonize, but because they're bacteria, they have their own little life cycle. They typically stick around in your GI tract for about 28 days, give or take. They pack up their bags and they leave through your stool. That's how they interact in nature. That's how they interact in our body. They don't live there forever. So there's a number of different bacillus types of spore-based bacteria that are on the market today. Here are some that are well-researched and that provide different benefits. Again, going back to that strain specificity. Here we have Bacillus subtilis, the HE58, that produces natural antibiotics. But cool thing is, it's not going to damage your commensal and healthy organisms. It actually targets more pathogens. Indicus, HE36, is a very potent immune support, but it also supports the production of carotenoids, astaxanthin, beta-carotene, lycopene. It's kind of like a multivitamin in a bacterial form. So those types of nutrients feed other bacteria in that rainforest. Clausi, really important for immune health. There's really cool studies between the gut and the lung axis. So patients in pediatrics that suffer from upper respiratory illnesses and infections, Clausi becomes really useful there. Coagulants, probably the most widely used in the market today, but it's really good for producing lactic acid and supporting immune health. And then licheniformis, also producing a lot of B vitamins, because your gut microorganisms rely on micronutrients just like we do. And in fact, you get to absorb some of them into your body. They contribute to your micronutrient pool. So pretty cool. Now, again, when we put all this together, 3 steps, hoping to break it down by just addressing those 3 key layers of the gut microbiome. Fix the gut. Let's fix that foundation. I think spores are the best for this first step. Then you can weave in different strains of bacteria to help figure whatever your patient needs, whether it's for a gut skin axis, gut liver, with hormone balance, and so on and so forth. There's a lot of different solutions out there. Reinforce those changes with oligosaccharides. Even if we're on a keto diet, it's not gonna contribute to that. The only patient I would avoid it with would be a SIBO patient until you're past that type of infection. Otherwise, safe for use. And then rebuilding the mucosal barrier. So using these immunoglobulins, polyphenols, and amino acids that helps to build a really thick and robust mucosal barrier to prevent your immune system from overacting and overreacting to the world around you, from food particles to bacteria, becoming really important as an immune component. So what do we do with all of this? There's a lot to absorb. Metabolic endotoxemia. What is it? It happens when you have a lot of permeability in that barrier, loss of barrier integrity. Your immune system is being turned on, causing a surge of inflammatory markers to go up, creating a low-grade chronic inflammatory state. And so we know that this is linked to many chronic conditions that we face today, especially neurological. Now, we can implement different strategies to help correct the gut microbiome, fix that foundation, utilize psychobiotics to prevent neurological conditions from worsening. And, definitely, there's a lot of different tactics that we can implement, from diet, lifestyle, and nutraceuticals to help get your patient's gut health back on track.
Amazing. Okay, so I'm going to summarize my 3 takeaways. So let's see if I got it. Number 1, what happens in the gut does not stay in the gut. So we want to make sure that we understand the way that diet, environment, dysbiosis is going to have a implication system-wide. And number 2, we want to nourish the rainforest. So we want to supply the gut with all of the fuel that it needs so that we can have a lush rainforest and a soil that's ready for us to cultivate as much diversity of the microbiome as we can. And number 3, as we can then seed and apply these strain-specific, iPhone-specific, or Android, if you're an Android user.
Right. Don't want to discriminate.
We don't want to discriminate, but we want to have a very specific application. As we learn about that, start thinking about the types of strains that you can then plant in that lush rainforest, so that you can get the exact outcome that you're looking for your patient.
Absolutely. We're not smarter than our gut microbiome. We shouldn't try to be. Let's just utilize really good tools to get it where it needs to go.
I love that. Now we're running a little bit late. No, this was fantastic. There's so much great feedback in the chat that I'm looking at. So everybody seems to have appreciated this. There's a couple of good questions in there. Can we maybe squeeze in 2 questions before we wrap up?
Yes.
Okay, amazing. Okay, there's a couple of questions about H. pylori. I'm gonna sort of wrap them up a little bit so that we can get as many of them as we can. But question on H. pylori and SIBO, you touched a little bit on that. Anything that you can teach us about how to leverage either strain-specific approaches, or how do we really move people in? Because those are very refractory. In my experience, we keep those patients keep coming back with those infections. How do we, 1, address them, and 2, keep them healthy long-term?
Yeah. Addressing them, make sure you have the right diagnosis. Don't start guessing. Test, don't guess in those situations. Absolutely. Because when you start throwing around antimicrobials without having the proper information in front of you, you can do a lot more harm than good. So number 1, please start with a really good test that is backed, again, by research and clinical data. Number 2, yes, the recurrence of those two in particular becomes quite difficult, especially because we're dealing much more upstream. When we're thinking about H. pylori and SIBO, and oftentimes they can be happening at the same time, you're really dealing more with the stomach and the small intestine. So some of this type of therapy wouldn't necessarily apply. We're really more focused here on the colon. But with SIBO in particular, I do tend to veer more toward the allopathic applications just because the research is stronger there. So using some pharmacological intervention can be very helpful along with diet therapy. Would not use a prebiotic in a SIBO patient at all because you don't want to feed that infection that's living in the small bowel. And then once you've completed your SIBO treatment, symptoms are subsiding, wait. Just wait, because the recurrence rate and the relapse rate is so high. And I understand it is so difficult for those patients and what they're dealing with because they want to get back to normal. But I wouldn't start utilizing any sort of oligosaccharide in those moments. You can use spores. HU58, Bacillus subtilis spore is particularly useful because it can actually create antimicrobial compounds to attack the infection. They actually have an affinity for H. pylori as well. So HU58, Bacillus subtilis is useful for both. And then for H. pylori in particular, again, pharmacological therapy is useful there too. I'll leave my opinions on if they go overboard to the side, but you can utilize a dead strain of bacteria. It's a Lactobacillus reuteri that it's almost like, I call it like a Velcro, where it can attach itself to H. pylori, removes itself from the gastric mucosa. It's shuttled out of the body through the stool without damaging the gut microbiome. So really cool ways in which we're utilizing bacteria in new ways. We can use dead bacteria for very specific purposes. Has nothing to do with the gut microbiome, but we know it can bind H. pylori. Super cool.
And you said something really important, test, don't guess, because those two both show up very similar symptoms. They could occur at the same time for sure, but you could be addressing the wrong thing. And there's a bit of a difference. And then I just want to add a little bit of a clinical pearl there. I love that you said, wait, don't jump right in with the prebiotics. I couldn't agree more. And when I hear wait, I go, okay, this is when you could go in with all the foundations, helping them support their migrating motor complex, the vagal nerve, motility, using things like herbal bitters and motility support to make sure that things are moving. Because in my experience, most of those patients, their motility is very sluggish. So if we can kind of get that motor running, sort of say, that really helps to reduce the risk of that recurrence. So then we can start expanding on those prebiotics. And I think that's a great opportunity for things like butyrate and things like that. So that's great. A question specifically on some of the formulations. There's a question about capsules over powders. The Mega IG 2000 in particular. I find it very hard to dose capsules. They end up taking a lot of capsules for me to get to therapeutic dose. Does it make a difference? What's your therapeutic target there, and how do you see that apply, particularly when we're looking at a stool test and seeing those elevated inflammation levels, like elevated secretory IgA, et cetera?
So format first. Does it matter if it's a capsule, a powder, a gummy, an oil suspension? There's so many ways you can take supplements these days. No, it shouldn't matter. And the companies that you work with should know the stability data of what they're working with. I am one of the people that I hate taking pills. I can take one pill a day. It's like a phobia of mine, despite working for a nutraceutical company. So I take things in powder forms, and I find that it's easier to be flexible with the dosing. You can hide powders in smoothies, yogurt, whatever you're consuming, some sort of porridge. Now with IgG 2000 in particular, I like dosing that on its own, not mixed into anything, not mixed into like a bacterial blend or anything like that, because I want to be very personalized with it. Now, in some clinical studies, especially on C. diff, you can up that dose dramatically. Usually the recommended amount is around 2 grams per day. You want to take that 2 grams, hopefully 1 gram at 2 meals. So you're getting this trickle effect of the IgG getting into your body, kind of creating that neutralization, that sponge effect or the lint roller effect. But if you have someone with a gut infection, or if you have laboratory data to suggest that you have pathogens or inflammation in the gut, you can go up to 5, 8 grams. And And I do. And I absolutely do if I see a gut infection. And you still want to break up the dose to a number of doses per day, get that trickle effect. And you need a compliant patient for sure. If you're doing that, you might want to minimize other things just to give them a break. But you'll find good relief there.
And I've personally in those patients, and we've all probably seen those that are very sensitive, like you have to be very careful. I very rarely see anybody have a negative reaction to SBI. I've never, honestly, I think it was once, and I don't think it was the SBI if I'm being honest, but that is a great, it's a great sort of stabilizer. And so I'll go to that higher dose and just hold on to that for a little while until that inflammation level starts to go down and I get a little bit more repair. And then we can start experimenting a little bit more, first with food and expanding diet. And then we can start with a more deliberate protocol. So I love that approach.
Drink a little extra water. That'd be the only possible side effect. It's a little slowing of motility, but usually that's resolved. You can even taper up instead of just throwing in 5 grams or something like that.
And I have to say, like, we've got to be addressing that vagal nerve motility piece too.
Gargle, hum, do all the things. Yeah. Magnesium
citrate, all the things, right? Absolutely. There are so many great questions. Honestly, some of these could be their own topics in the future. The gut microbiome with the kidney, IBS, SIBO, all these awesome topics. And unfortunately, we're not going to be able to get to all of those. I will say this was recorded, so anybody who has to jump off or just wants to listen to it again and really absorb it. And I will pass the mic over to Amy to give you some more of those details and take us home, Amy.
Thank you.
Excellent. Well, thank you so much to everyone who attended today. And also thank you so much to Lacey Hall and Lara Zacharia for this great presentation. Look out for an email with a link to view this recording within a couple days. And anyone who has any additional questions can send them right over to me. My email address is amy.regan@fullscript.com. And I hope everyone enjoyed this presentation as much as I did and has a great rest of your day. Thank you so much to the both of you as well.
Thank you.
Thank you guys so much. I appreciate it.
Excellent. We'll see you soon.
See you soon.